कि मैम लॉग इन नहीं कर पा रहे।
नहीं, जब तक थिन एंडोमेट्रियम हो जाएगा लोग ज्वाइन हो जाएंगे।
So Deepin, please make it live on the YouTube. I'm starting.
Okay, sure.
Yeah. Thank you, Deepin.
We can start. We are live on YouTube.
Yeah. So hello everyone, warm welcome to everyone, all those my friends who have joined all across the geography. So friends, I'm here, Dr. Ritu S Santwani this side, founder and CEO of 360 Degree Healthcare Studio. I'm doing my first program on the DigiShield app. So thank you Deepin for this. So my all presentations will start with the Durga Mata Stuti, whether the national or international. So, Ya Devi Sarvabhuteshu Chikitsa Rupen Sansita Namastasyai 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 Namo Namah. So, this talk, though I have taken so many times in different platforms, still I always get the request for the management of thin endometrium and ovulation induction protocols. Last week only I have taken the ovulation induction protocol, still I received, so maybe I plan on the coming week for the ovulation induction protocol again. So today I am going to discuss how can we manage the thin endometrium and what are the tips and tricks and what is new in the advancement for the management of thin endometrium. So I tried to make this my talk little simplifier. There is a famous quote by the Albert Einstein: if you cannot explain it simply, you do not understand it well enough. So friends, I have put all the practical aspects in this my talk. So all of you are free to interrupt in between or can put your marks in between also, so we can discuss at what protocol you are using. So mutually we can be benefited. It is not like the monotonous that only I am speaking. So now what are the hard facts as we all aware? Healthy seed is not enough to get a healthy sampling unless it grown on a fertile soil. Similarly, healthy embryo needs the receptive endometrium for the successful implantation. So here we can see, as for the implantation, the endometrial receptivity, embryo quality, and transfer efficiency is very important. So what the studies suggest, what about the incidence of the refractory endometrium? The prevalence is 2.4%. Endometrial thickness under 7 mm would define a refractory endometrium with compromised success rates. 8 to 13 mm is favorable. Less than 6 and more than 15 mm will be the problematic. Though we have seen practically in our experience, the patients with the thickness of 2.53 also sometimes conceive. So as we all know, the bottleneck is the process of the implantation. So this is where we can see the thin endometrium, management of that is very, very important towards the window of implantation. So here we can see for implantation, the good embryo and the good endometrium is required. So the embryo-maternal connection. So receptive endometrium requires the estrogen priming needed for endometrial proliferation and the development of P4 receptors. Time-related progesterone induces the secretory changes in the endometrium, while the other molecules IGF, BP1, prolactin, laminin, type 4 collagen, fibronectin, heparin sulfate, integrin, cadherin, adherin, secretin, and so many other factors. Among that, VEGF, TGF, beta, and TNF alpha has been reported. So endometrial thickness by ultrasound, how we measure. Some friends are not able to join. Okay. The program is just a second. Type there, the program is going live on YouTube. Yeah. So the endometrial thickness is by ultrasound. While the benefit of ultrasound to characterize the follicular development is very well documented, its value in the endometrial evaluation is less clear. Endometrial thickness is directly correlated to increasing circulating estrogens. Endometrial thickness is related to endometrial receptivity and can be a predictor of success in assisted reproduction. Here in this diagram, we can see a good triple layer endometrium, because these days the patients are so much of Google savvy. They always ask, ma'am, you are telling the endometrium thickness. What about is it the triple layer or not? So in 10% of the cases, then ideal image for measurement is difficult to obtain due to the presence of fibroids, adenomyosis, polyps, uterine orientation, body habitus, previous surgeries, and the patient intolerance. So as we know, the study has been supported by the Fertility Study Journal. For the ideal endometrial thickness of 9 to 14 mm is associated with higher implantation and pregnancy rates as compared to the endometrial thickening of less than 7 mm. So here we can see this diagram is showing this blue color for the ET less than 7 mm, and this maroon color is showing in between the 9 to 14 mm. So the implantation rate in this case is 12%, while with 9 to 14 it has been reported 19%. Similarly, the clinical pregnancy rates 18% versus 30%. Ongoing pregnancy rate 16%, 27%. Live birth rate 14%, 25%. So now, what are the causes of thin endometrium? As we all know, the Asherman syndrome, which we see most commonly in India, CC, prolonged use, postpartum endometritis, septic abortion, pelvic chemotherapy, hypothalamic hypogonadism, fibroids, Mullerian anomalies, premature ovarian insufficiency, hyperandrogenemia, iatrogenic, and idiopathic. Studies of patients with thin endometrium often excludes the patients with other uterine pathology. Therefore, the true incidence of uterine pathology is not well reported. So now, what is the treatment for this thin endometrium? As we all are aware, the hysteroscopic adhesiolysis, estrogens, aspirin, vitamin A, pentoxifylline, L-arginine, or the use of the sildenafil. Among this is Gcsf, HCG, PRP, stem cells, uterine transplant, and surrogacy. As we all know, still there is a lot of confusion regarding the use of Gcsf. I get a lot of queries that how to use this Gcsf and how to use the sildenafil. So I will take one by one. So based on the etiology, number of drugs methods has been used with the aims of improvement in estrogen levels in endometrium and increase blood supply to the basal endometrium. So as we all know, due to the anti-estrogenic effect of the clomiphene is the major drawback the patients are having the thin endometrium. So in that cases, the use for the ovulation induction either by letrozole, tamoxifen, or gonadotropins have the advantage of avoiding the peripheral anti-estrogenic effects. So now, with what doses we can use this estradiol? Either the oral route, the patients can start with higher doses, 6 to 8 mg or maximum up to 16 mg has been reported. While some groups have suggested maintaining the higher doses for up to 9 weeks with no adverse effects such as endometrial hyperplasia or bleeding, transvaginal estrogen administration, and it is a very good alternative to obtain the high serum and endometrial tissue concentrations of estrogens. estradiol patches achieves the good serum concentrations of serum estradiol. Several patches must be used to achieve and maintain the serum concentration. In some patients who are intolerant to the estrogen tablet, we are using the gel also. That is also giving the good results, though in limited numbers, but still the studies have also been reported. Either the conjugate equine estrogen or the transdermal ethinyl estradiol or the vaginally administered local estrogen to avoid the first pass of systemic estrogen. So if we are getting the thin ET in the fresh cycle, then to change the stimulation protocol, or we can add the estradiol, we can add other adjuvants or the freeze-all policy. So here we can see the fresh cycle, the addition of the estrogen. So here we can see with the studies have shown with 2 mg, it's a reported 32.80, while with 6 mg is up to 51.30 has been reported. Estrogen in the agonist cycle. So here we can see the studies with this. No E2 is the report rate as reported pregnancy rates are reported 23.1, while with low dose E2 32.8, while with high dose E2 51.3. But we have to keep in mind all other parameters also regarding the body weight of the patient, and especially in the metro cities regarding the smoking, because I do get mostly the patients who are chain smokers or very high incidence of the smoking. So we have to be very conscious whenever we are using this. We have to ask the patient very clearly about the history. So yeah. So studies have come which endometrial preparation for FET, the natural cycle or the hormone replacement cycle or the stimulated cycle. So pure natural cycle or modified natural cycle, or if we are giving the replacement therapy, then with the down regulation or without down regulation. Studies have come from the Canadian Fertility and Andrology Society guidelines. The studies have shown the patients with a history of thin endometrium in ART undergoing the endometrial preparation for embryo transfer. There is insufficient evidence that any specific protocol, natural cycle or hormone replacement for endometrial preparation provides the better pregnancy outcomes. So this hormone replacement cycle, the exogenous supply of estrogen and progesterone that equals the effects of ovarian hormones on the endometrial tissue is required. Here we can see amongst the studies how with this increasing dose the good results are there. But as I'm saying again and again, there is nothing like a tailor-made protocol. We have to judge in each and every patient considering all other factors too. So the studies have come regarding the superiority of the estradiol valrate over the other estrogen, because there are these days so many other estradiol valrate, estradiol hemisuccinate. So many each and every day we are getting some of the other companies launching some or the other preparation. So I have included only some in this. So ethinyl estradiol, increased triglyceride. And with this factor 8 in PRA, the hypertension and coagulation chances increases. With conjugated estrogen, the interbatch variability, allergic reaction, PRA, hypertension. With increased factor 7, the increased coagulation. With estriol, increased LDL, while with transdermal patches, inconsistency between the products, reaction and problem in humid atmosphere. Which is very commonly seen. Estradiol transdermal gel, decreased bioavailability and skin reaction. Friends, before I move to the another slide, Let me know the opinion of all of you, that what you are using for this, which preparation you are using of the estrogen, and why so. Are you getting the best results from which preparation? So I am able to see so many friends have joined across the geography also. So please write in the chat box that which preparation you are using and how you are getting the results. Dr. Upma, please write in the chat box. Dr. Chinwe always joins my webinar. Yeah, Dr. Samuel from Africa. Yeah, Dr. Samuel, please write which preparation you are using. Hi, Dr. Rosie. Good to see you from Nepal. So please drop in the chat box that which preparation you are using and how you are getting the results. So I want this interaction should be, this should be a proper interaction instead of monotonously I am speaking. Dr. Kiran Oswal, I want your opinion also. Yeah. So let me finish this, then we will discuss one by one. So there are different studies are there. The prolonged estrogen treatment prior to the frozen blastocyst transfer decreases the live birth rate. So the studies, different studies have come from the fertility and ASRM. Regarding the use of the estradiol treatment and influencing of the clinical outcomes. Again, the studies has been presented that due to this endometritis, the leading cause of the infertility in the endemic countries, which causes the implantation failure by immune modulation of the endometrium by causing hormonal imbalance and by releasing antiphospholipid antibodies. So studies have shown for the good results, we have to manage this endometrium. So the targeted therapy is appropriate when the cause of the endometritis is known. So now coming one by one, first the studies have come regarding the use of the vitamin E. So a lot of studies regarding the favor of support of this vitamin E. The dose is 600 mg per day, means 200 mg TDS has been reported. Along with this, the studies has been presented by the Takasaki. The studies have shown the adequate ET in 52% patients following treatment. 72% have showed the improved resistance index in radial artery resistance index, and 20% is conceived. So studies have shown that vitamin E improves the growth of the glandular epithelium and number of blood vessels and VEG protein expression. I think vitamin is very good compared to the other supplements what we are giving. Is cheap and very easily available. Now coming to the sildenafil, as we all know, regarding this also there are a lot of queries in everybody's mind, because recently I attended one conference. There are a lot of doctors are asking me, youngsters, ma'am, how to give and regarding the sildenafil and arginine also. First I will take this arginine. So it improves the uterine blood flow, endometrial receptivity and implantation. As we all know, it's a nitric oxide donor. Nitric oxide relaxes the vascular smooth muscle of the endometrium. The dose is 1.5 gram 4 times, and it improves the radial artery resistance index in 89% of the patients. 67% of the patients develop the endometrium more than 8 mm. So now, yeah, before I switch for this probiotics, regarding this sildenafil, how many of you are using for the management of thin endometrium and you are getting good results? By what dose? Are all of you are using the QID, or by the QID dose your patient is giving the complaint of this headache? So what dose you are using in your practice, please do write in the chat box. So once I finish showing the slides, we can discuss these points. We are having so many stalwarts with us. We are having my dear friend Dr. Shivani is with us, the surrogacy queen. Later on, last time coming for that, for the what is there, we will discuss regarding for that. Dr. Yajini madam has also joined. I'm able to see Geeta Khanna madam also from Lucknow. So we will discuss one by one. We are having so many stalwarts here, so we can discuss these parameters one by one. So friends, do write in the comment box that which preparation you are using. Now, there are a lot of studies have come regarding the use of the probiotics for endometrial health. Yes, we will discuss one by one. One by one, we will discuss everything. Please do write in the chat box. Let me finish this, then we will discuss. So, microbiota is a crucial player in the gynecologic health, in which the bacteria can shift to a dysbiotic state, triggering a pathogenic process. This classification helps predict the reproductive success in terms of the implantation, pregnancy and live birth rate, showing that NLD microbiota, especially with the presence of Gardnerella or Streptococcus, is strongly associated with adverse reproductive outcomes when compared to the subjects presenting with LD endometrial microbiota. How many of you are using the probiotics in the treatment of the thin endometrium? Yes, I am of course using. I am using in my patients of endometriosis also, getting the very good results. Sorry. So here's the study from the PubMed. The studies have shown, we can see here, the study have shown that Lactobacillus rhamnosus was demonstrated to have a protective role on the endometrial infections and in vitro model of the bacterial colonization of primary endometrial epithelial cells with Atopium vaginae, Gardnerella vaginalis, Propionibacterium acnes, and Streptococcus agalacti. The studies have shown that this Lactobacillus rhamnosus, endometrial health and gynecologic pathogens, probiotic and pathogen inhibition. So a lot of studies for the support of that. Now coming to this very commonly drug, as we all know, before all these, we all are using the sildenafil. So the studies have shown it improves the uterine blood flow. Phosphodiesterase inhibitor that prevents the breakdown of cyclic GMP and augments the action of nitric oxide on vascular smooth muscle, along with estrogen, leads to proliferation of endometrial lining, regulates the cell growth, angiogenesis, and thus facilitates the implantation. So doses, what has been recommended is 25 mg vaginally 4 times a day till the trigger. But in my practice, I am using up to the TDS, not QID, because patient complains a lot of headache, even though I give vaginally also. So studies have shown that tumor suppressor factor, a plasminogen activator inhibitor, and vascular endothelial growth factor need to produce necessarily to digest the endometrial cellular matrix, to regulate the cell growth, and angiogenesis to facilitate the implantation. So the sildenafil markedly enhance the P53 and PI1 with the increased VEGF. So here a lot of studies in the favor of this, that oral sildenafil improves the triple line pattern, endometrial thickness, and the endometrial receptivity. Now coming to the other important thing is the pentoxifylline. Though I have no experience with the use of the pentoxifylline, but the studies have shown regarding the use of this pentoxifylline for this, and the doses they have recommended 400 mg for 5 days. I have not used in any of my patient for this. So if anybody of you have used for this, please do write in the chat box so we can discuss later on. Taking the other slide. Yeah. So regarding the use of the aspirin, the studies have shown the low dose aspirin in the patients with thin endometrium, if started with a lot of studies are not there, but some studies are there that it helps in increasing the thickness, but not too many studies. So studies have shown This study has been presented regarding the use of the vitamin D. So of course we can give vitamin D. The study have done on the 110 patients. There we have they have shown the vitamin D versus the placebo group in between the two groups. Studies have shown the vitamin administration of vitamin D induces the endometrial proliferation in PCOS patients during the during the IUI cycle. Now, again, some studies have been presented regarding the use of this HCG priming. So, HCG endometrial priming for 7 days in the proliferative phase with estrogen in frozen cycle seems to be highly promising. Then the studies have come that HCG priming of the endometrium leads to significant improvement in thickness and pregnancy outcome. 150 international unit HCG from day 8 till day 14 or 15 with estrogens in FET and donor egg cycle. So studies have shown that this HCG was administered from the 8th day of the cycle. On the 12th and 13th day, the transvaginal sonography was done. Studies have shown that if the endometrial thickness was proper, HCG stopped, and after 24 hours, the progesterone 100 mg intramuscular injected for 3 days. The studies have shown that addition of the HCG to conventional preparation was an effective protocol and was significantly improved the endometrial thickness and pregnancy outcomes in women with previous embryo transfer because of the thin endometrium. So there are different studies. Some studies support this, some are not. So these are the different studies in this slide. So now coming to Gcsf, I think in the 2012 or 13, I used lot of Gcsf, and when it has been recently launched, and that time definitely I found the very good result with the Gcsf also. So this has been launched by the Nobel Glacier et al. At 2011 was the first to use in 4 patients with dramatic improvement in ET. Improves the ET in patients with thin endometrium, especially when it is due to destruction of the subendothelial layer and where the other treatment for vasodilation have failed. So, as we all know, that this Gcsf is a glycoprotein with growth factor and cytokine functions. Studies have shown, studies have shown that how the proliferation and differentiation of the normal human endometrial stroma. It has been proposed for the treatment for the implantation failure and repeated miscarriages. The mostly assumes the immunological process. So as we all are aware, it is a glycoprotein, growth factor, and cytokine. The sources, as we all know, endothelial cells, monocytes, macrophages, and fibroblasts. Reproductive tract promotes the neutrophil proliferation and maturation. Produced by recombinant DNA technology from E. coli, in which the human Gcsf gene has been inserted. So friends, now again, please write in the comment box that how many of you have used this Gcsf and how many of you are happy with this Gcsf results. So those who have used, please write down the comment in the chat box that if you have used, you find a good result with a single shot, or you had given 2 or 3 shots for the Gcsf. And you have used of course, the intrauterine one, or some have used for the subcute also. So with which preparation, with which mode you have got the good results. So this is the mechanism of action, how it acts, recruitment of the neutrophils, vascular remodeling, endometrial proliferation, uterine gland transformation, endometrial decidualization and thickening, increases the blood supply, and due to VEGF, the growth of the new blood vessels. These are the different studies that has been presented by the different authors regarding the use of this. So here we can see the one famous study by the Nobel Glacier. They have shown 2 to 7 days before the embryo transfer. Dramatic improvement in the endometrial thickness in all 4 patients conceived and with 1 intramural ectopic pregnancy. So these are the different studies presented by the different authors. So for the endometrium, as we know, it is secreted apically in polarized epithelial cells. Gcsf has been proposed as the treatment for implantation failure and repeated miscarriages. A growth spurt in the endometrial thickness can be observed within 48 hours of Gcsf administration. So here it has been shown that what is needed: the IUI catheter, insulin syringe, lithotomy position, partially full bladder. So these days, we all are using the pre-filled syringes, so that is also good. Or otherwise, if you are taking a vial, you can use by this method also. So usually what the protocol has been recommended is the ovulation induction trigger with HCG, 10,000 international units. Once the follicle reaches more than 19 mm, diagnosis of unresponsive thin endometrium less than 7 mm by the ultrasound on the day of the HCG administration. Then doses has been recommended 300 microgram per 1 ml approximately 6 to 12 hours before the HCG administration, and this has to be repeated Gcsf infusion if endometrial thickness is less than 7 mm on the day of the ovum pickup or the day of the IUI. So usually the dose is it contains a 300 microgram per ml. So studies have shown that if it is given with 1 ml insulin syringe 6 to 12 hours before the HCG administration, the results are more good. Now coming to the what's new, because still a lot of doctors having a lot of confusion regarding this PRP. So a modern medicine boon for the repair, restoration and rejuvenation. So friends, for this PRP, first I will show the slides, then we will discuss. Yeah. So as we know, this PRP is collected from a peripheral vein. Through activating the platelets by clotting, releases the cytokines, growth factors, BEGF transforming growth factor, platelet-derived growth factor, and epidermal growth factor. So we know the platelets are the 2 to 3 microns in size, devoid of nucleus. DNA contains the dense granules and alpha granules. Alpha granules contain the clotting mediation such as the factor 5, 8, fibrinogen, fibronectin, platelet-derived growth factors, and chemotactic agents. Delta granules or dense bodies contains the ADP, calcium, and serotonin, which are the platelet activating mediators. So this platelet-derived factors help in the tissue regeneration, angiogenesis, epithelialization, proliferation and differentiation of osteoblasts, synthesis of collagen. Just a second, need water. So here this chart is showing the different factors which has been derived from this. So this is the mechanism of action. So friends, again, please write down that how many of you have used this PRP and how many of you find the good results with this. And if not, you find a good result, then for how many cycles you have used. Please do write down in the chat box. I am seeing only the one person is writing. So only one person has been replied. So the mechanism of action for this, as we all know, the activated platelets releases the granules by exocytosis, which contains more than 60 different biologically active substances that are involved in the processes of tissue regeneration, angiogenesis, and epithelialization, proliferation, and differentiation of the cells, and the synthesis of the collagen and extracellular matrix of connective tissue. So this is regarding the PRP. So the studies have come that the intrauterine infusion of PRP is used in endometrium with the view that the growth factors provided by platelets will help in restoring the deficient endometrial function. So friends, here what I am showing is the method what I am using with the double spinach method, but now these days with the single spinach also the lot of PRP kits are available, so that is also good. As the technology advance, we have to shift on that. I'm still having a lot of stock of the this, so that's why I'm using this. So those who have not, so instead of double spin, the single is also available these days. So PRP is prepared from 15 ml of the blood using the double centrifugation, and final preparation of 0.5 ml has been infused on day 10 and additionally on day 13th of the cycle. So friends, if you are using the PRP, what protocol you are using, please do write in the chat box. So we can discuss. So we won't miss any point. So, so different studies are there. I think lot of backside noise you must be getting. So different studies have shown regarding the use of the PRP intrauterine infusion, which might be a new alternative for patients with poor endometrial growth. So the studies has been presented by the Leland Hazari et al. At 2016. The effects of studies has been supported by the so many journals. The effects of the autologous PRP in implantation and pregnancy in repeated implantation failure. So again, there are a lot of studies regarding the treatment of thin endometrium with autologous PRP. So the studies have shown for this in the chronic endometritis and endometriosis, which causes the inflammatory process, the PRP gives the anti-inflammatory effect and and the cell proliferation effect. PRP increases the progesterone receptor activity. So as we all know, this PRP is an office procedure that involves the withdrawal of the blood, preparation of the PRP, and injection of into the diseased area by the following steps. So here we can see after the single time in the incubator how it shows the plasma comes up 55% WBC and platelets. And in the down we are able to see the red blood cells. So usually in this the PRP test tubes of 15 ml and transfer and PRP transfer pipettes. These are the some that what we are requiring in the our setup. So in this usually we take the 15 ml of the blood, 1.5 ml of the anticoagulant and 13.5 ml of the blood using the scalp insert directly into the anticoagulant added tubes. Ratio of 1 ml of anticoagulant and is to 9 ml of the blood should be maintained. So here, as you have shown, the first time once we do the centrifugation, the first time which has come, the upper two-third portion, we have to discard of the plasma as this volumes of PPP, platelet poor plasma. So the pellets are homogenized in lower one-third to create the PRP. So the studies have shown that transfer the plasma to the another tube using the sterile pipette without picking the RBCs. Plasma can be pulled to the one tube if possible. So the studies have shown for this centrifugation. Just a second. Yeah. Studies have shown the centrifugation of 3500 RPM for 15 minutes to get the platelet palette. The upper plasma layer should be very clear and should not show any swirling platelets when shaken gently. If the sweating seems centrifuge, the further 10 minutes to get the clear plasma. So these are the different protocols. So which protocol you are using, the friends, please do write. So leaving behind the 10% of the plasma above the pallet, we have to discard using the sterile pellet. We have to resuspend the pallet particle, sorry, so the platelet pallet in the remaining plasma using sterile pipette and loading with the syringes. And because this gives the concentration 7 to 10 times higher. So this is the different methods how we are preparing. So the study has been supported. This is a very recent study from the JBRA Assisted Reproductive Journal 2022 March. The study has been supported that although platelet-rich plasma optimizes the endometrial thickness and pregnancy outcomes in women with refractory thin endometrium of the varied etiology of the fresh and frozen thought improve transfer cycles. Similarly, regarding the use of this cells from the bone marrow, so yeah, some studies are there regarding the favor of that. I have no experience with this bone marrow cells for the management of this. Again, the studies have shown that subendometrial autologous stem cell transplantation of mononuclear stem cells has been derived from the iliac crest. In 6 studies have shown done in the 6 amenorrheic women with the refractory Asherman syndrome. They shows a significantly improvement with endometrial thickness by exogenous and estrogen therapy. So there are the different studies regarding the use of this also has been published. Again, the studies have come regarding for the neuromuscular electrical stimulation and biofeedback therapy is the another very recent improvement in the poor endometrial growth. So, yeah. Studies have shown regarding the use of the stem cells as new agents for the treatment of female infertility. So a lot of studies has been presented by the support of this. So the studies have shown, this is a very recent study published in 2022 only by Nasran Garibe and Leela Ageveti Melengi. So studies have shown that the cell therapy has been proposed and is an ideal alternative for endometrium regeneration, including the employment of stem cells, PRP, and growth factors as therapeutic agents. So, studies have shown the mechanism of action of the cell therapy include the cytokine induction, growth factor production, natural killer cell activity, and natural killer cell activity reduction. So the studies have shown the ratio about the TH1 and TH2. Again, the studies have come that It is the promising nature. Further research has been required for improvement of the procedure and the safety of this strategy. Again, the studies have come regarding this with the stem cell therapy. The ideal candidates, the patients with persistent thin endometrium and with repeated implantation failure, treated cases of the tuberculosis with the thin endometrium. So Asherman syndrome grade 3 are the patient who need it most. So these last few slides are the same as I have taken earlier also, because to summarize in this, it evokes the favorable inflammatory reaction producing the cytokines, secretes the proteases which regulates the endometrial function and thus improves the implantation. So if in spite of doing all these things, there is no improvement in the endometrial thickness and receptivity, then and no response, so better to advise the patient to go either for the surrogacy. Yes, of course, the uterine transplant is not yet as popular. Uh, So here we can see in this diagram the trilaminar endometrium. Dickey and Helix found the the results in the endometrial thickness less than 7 mm, and they have found, the studies have shown the pregnancy rate was higher, 12% versus 8% in the trilaminar versus non-trilaminar group. So to conclude, we have to select the best seed, we have to prepare the best soil and plant at the appropriate time. Taking a different approach achieves a pregnancy in many cases that have failed repeatedly. So soil thickness of 7 mm to achieve the good this Gcsf endometrial scratch and stem cell therapies are a promising nature. So thank you, dear friends, for your patient listening, and thank you DigiShield app, especially the Mr. Deepan, for inviting me here. So we have learned from yesterday, leave it for today, hope for tomorrow. And the important thing is not to stop questioning. So here is a description of some online courses, what I am doing along with the ma'am. It's the Middle East Association of this Gynec and Ops and Genitalia Aesthetic. So thank you, dear friends, for your interest and your time. So now I will see in the chat box that what comments we have received. So yeah, good to see you, Dr. Crow, for joining. Yeah. So questions are not opening. Yeah, hi, Dr. Chinmay. Regarding the endometrial scratch, yes, earlier we all are using still also, but now not like in the, we have to go in the OT and give the anesthesia and then to do nowadays with the simple people you can do in the OPD also. Yes, of course, there are the some studies are there, but we all once we pass out that generation, we all are using it. Personally, I am using the endometrial scratch. Yes. I'm able to seeing the questions. Yeah. So let me go to the chat box. Yes, I will take one by one now. Checking for the questions. Yeah. More messages are coming. Dr. Kiran, thank you for joining. Yeah, but in some patients, I find good results with vitamin E, maybe a placebo therapy. One of my patient with she was not ready for the PRP also. So for the 2 cycles I had given her for this vitamin E, very good results I find. Yes, Dr. Upma, yeah, thank you for joining. Yes, you are using, yeah, in some patients PD and in some patients we are using the TDS also. Yes. Mm, yes. Uh, this is regarding this GCSF, yes. Checking for the questions, yeah. Dr. Lalita, as has been recommended, as you have asked regarding the endometrial stretch during the FET cycle or before the cycle. Yes, of course, the before cycle, same has been reported for the day 21. So, yeah, hi Yukti for joining. Okay, this is also Sharmila madam has also joined. Yes, the estradiol well rate. Yes. Yes, Dr. Kiran is writing the estradiol valid and the patches. Yes. Yes, Yukti. Yeah, some yeah, most of us are using this Progeneva also. Correct. Huh? Uh, yes, Sildenafil is also. Try to use the probiotics in some resistant cases. I find the good results. Uh, yeah, Dr. Arjuman is writing that she has been using the for this doses on alternate days before the transfer giving subcutaneously. No, but I am using in the thin endometrium is always the intrauterine. Okay. Let me see some more questions are there. Yeah. Yeah, Dr. Lalita. Yeah. Dr. Lalita is asking, can we give this GCSF and PRP in the same cycle? So which one is first and for how many days gap? So Lalita, why you want to use both in the same cycle? There is no such study that we can't use both in the same cycle. But if your patient is ready for PRP, so I to of course prefer and opt for the PRP only. And you are writing the for the which day, and so just a second. So just a second, question has been gone somewhere. Yeah. So that depends on that. See, usually the different studies by the different authors has been there. So, but I, because for these patients monitoring, I am doing the sonography myself and seeing. So usually I don't wait till 9th or 10th day. By the 7th day, I will take the judgment if I'm finding that endometrium is not growing. So I'm planning to give on that day only. 7th day ko, if I'm seeing that it is not growing, I will talk to the couple and counsel them, and if they are ready we will try to give on the same day or on the 8th day. Then again I will see on the 10th day. So I have never tried that both in the same cycle, so nothing like that. So because these days my choice is the PRP only. Yeah, but in some patients I'm using still the GCSF too. So let me see. Yes, Dr. Komal, yeah. The role of AKT for the thin endometrium, yes, in some cases of the Asherman syndrome, baki not only for this, that only for thin endometrium we are using. If there is a history or you are getting that, you can use for that, yeah. Yeah. I think I have taken all the questions. Let me check on the YouTube also. We are receiving some comments there also. Yeah. Yeah. Dr. Archuman is writing method of installing the intrauterine Gcsf and from which day to start and how many doses before. Just a second, I'll go through this. Before the transfer. Dr. Arjun, as I told you, I take the decision by 7th day only. I will observe and see that how my patient is responding. If no result is coming, so yes, I can repeat again on the 9th day also. So how many doses? There is nothing like that. Some clear cut that you can use only 2 doses or 3 doses. Maximum up to 3 doses I have used in some patients. So yeah, let me see more. Okay, yeah, hi Yukti. Ma'am, how often you use tamoxifen for thin? Very less, Yukti, very less. In the patients, those I think yes, they are not ready or they are not able to go for this PRP treatment. In that patients only I try the tamoxifen. You can say in 3 or 4 patients in a any result of, let me see what is it in. Yeah, hi Dr. Rajeshri Mahajan, good to see you from where you are. Thank you for joining. Similarly, I'm able to see Dr. Yogesh Vani also. Yeah, thank you for joining. Yeah, and Dr. Komal is writing any result of doing the transfer, how to start, any to and when to add. I'm not getting your question. Can you please elaborate again? Yeah. Now I got it. Yeah, she has written another comment. Even if TB PCR is negative in thin endometrium, can we go for the anti-tubercular treatment? You can, but you have to, in this era, you have to explain the patient each and everything, that what are the pros and cons, and then if the patient is ready, you can definitely go ahead. OPD endo scratch. Dr. Priya, we are having a small PPLA. If possible, I will post the picture tomorrow in the academic group. I think you are in my academic group. So that is very easy. You can take the patient in the lithotomy position, jaise ki we using for the copper T insertion and removal. With a small PPLA, we are inserting and we are taking that and sending for the testing. So it's very easily, small PPLA are available. So very easily we can do. If possible, I will definitely do. Yeah. Now, there's one more question I have received. Okay, that is same we have discussed. Yes, Dr. Oswal. Usually I am using up to 75. I haven't used up to 100 because 75 mg dene mein either I use vaginally or orally. The patient, there are a lot of complaints of headache and all that. So yes, yes, L-arginine is definitely a very, very good results. Yeah. Thank you, Yajini madam, for your comments. Madam, thank you for joining too. So yeah, thank you, Dr. Shalu Kapoor. Also, I am able to see my so many academic buddies have joined. Thank you. So friends, those who are not the member of the academic groups, please drop me on this number I am putting in the chat box 98220 25023. So please put your name and from which place you are. I am happy to add you in the academic groups. We are having 5 groups, so 5 groups are full. I will definitely try to add in the some other groups also. So I think we will wind up with this. It's already almost 10. So thank you, dear friends, for joining. So no, not here. Please drop me on that number. Here I'm not able to take. Please drop on that number, write on the WhatsApp, Dr. Rajesh. Please drop on that number and write your name and from which place you are. I will definitely add you. My academic groups are purely for the academic discussion, so all of you are welcome for that. And thank you, Dr. Aniket. I always see Dr. Aniket joining my webinars. Thank you. Yeah, hi, Dr. Crow. How are you? Yeah, Dr. Sebak Shrestha has also joined. Yeah, hi, thank you for joining. So with this, we are winding off for the today. So thank you, DigiShield, also for providing the platform.
Welcome, madam.
Yeah, thank you, thank you. Yeah, hi, Dr. Nagamani. How are you? So with this, we are winding off for the today. So bye-bye. Good night.
Thank you, ma'am. Good night, ma'am.
Yeah, good night. Good night. Bye.
Bye, ma'am.
Yeah, bye.